Gamal in his series of webinar, and he's going to deliver a very challenging topic. Because it is interesting carrying a high morbidity and mortalities and with associated injuries because of it is anatomical and of it is physiologically inherited difficulties. So we are so interested to hear from Professor Gamal how we can diagnose this challenging and this very difficult type of trauma. Welcome, Professor Gamal, and the floor is yours.
Thank you, everyone. Thank you. Hope everyone is having a good day. So, Omar, can you hear me?
Yes, Prof.
Okay, Omar, we're just going to run a couple of cases, and then we'll discuss that with a couple of slides to get everybody on board.
All right.
The first patient is a 9-year-old boy who was riding his bicycle and hit a wall and came off the bike and hit his upper abdomen, kind of the epigastric region on the handlebar of the bike. And his parents first didn't really take much notice of that, but after a few hours, he started having abdominal pain. They brought him to the emergency room in your hospital. So you have a 9-year-old boy brought in by his parents. About 3 or 4 hours ago, he fell off his bike, hitting his upper abdomen on the handlebar of the bicycle and complaining of abdominal pain. He is awake and alert in some degree of discomfort, and you're about to evaluate him. Can you tell us how you're going to approach this child?
Yes, of course, Prof. So at this point, I've got a blunt abdominal trauma. As you mentioned, so we're going to start from the basic steps here. We're starting with the ABC, which is you mentioned that the patient is hemodynamically stable, alert. So my focusing examination here will be on the abdominal examination. So I will keep attention that there is no guarding, there is no evidence of peritonitis. And then in the same time, make sure that the patient is under supervision during the examination. It should be hemodynamically stable. So I actually would start with the blood test at the moment. So I'll send the blood test for a FBC urine. So we check for the hemoglobin, and then in the same time, I'll check for the serum lipase. I don't expect that the serum lipase will be high in the initial, I mean, I'm not sure how long this patient,
3 hours.
Yeah.
He came off his bike 3 hours ago.
Yeah, that's fine. So if I expected that there is evidence of pancreatitis secondary to the trauma, serum lipase could be raised. But at this point, I make sure that the patient is not peritonitic. So I check the blood test, serum lipase. If there's any suspicion of duodenal injury or evidence of traumatic pancreatitis, so I would request a CT abdomen.
Let's just go there for a second. Would be the first thing you would get is blood work. That's fine. Would you get any imaging other than CAT scan at this point? Yeah.
So we can actually do an abdomen X-ray, and then it actually can shows you
Is plain abdominal X-ray part of the standard protocol for trauma?
Yes.
It is?
No, it's not. No, it's not, Prof. Well, so the thing we do fast.
What do we get for a standard protocol of trauma in terms of plain film?
So we do fast. So we do abdominal ultrasound.
In terms of plain film, Omar, plain film, plain X-ray. What's the standard we get for plain film for in the initial evaluation of trauma, blunt trauma especially?
So we do a chest abdomen X-ray, AB view, if the patient can stand. and then we do an
Omar,
abdomen.
just stay with
So
me for a second here. Omar, do we get plain abdominal film? Is plain abdominal film part of the ATLS protocol for blunt abdominal trauma?
no, I don't think so, Prof.
Okay. What are the plain films that are in the protocol of ATLS to evaluate blunt abdominal trauma?
You do a pelvic X-ray to check that there's any pelvic fractures,
And what else?
and then you may do, a lateral abdomen X-ray.
No, Omar. No, we don't do that. We never really do this in blunt abdominal trauma. We do plain film of the chest and plain film of the pelvis. These are the two standard plain films for the evaluation of blunt abdominal trauma in a trauma bay. And in children, even at the age of 9, you can safely get those. There is not much exposure of radiation. So you can get a chest X-ray and you can get a pelvic X-ray, okay? Even the pelvic X-ray, you can actually forget it because probably the child was walking, and if his pelvis is stable, as we talked last week, sometimes you don't really need to get a pelvic X-ray. Now, so you definitely need to get a chest X-ray to evaluate for possible pneumothorax. You don't know the mechanism, how he fell. Maybe he has a rib fracture. Maybe he could have a hemothorax. So you definitely need a chest X-ray. Chest X-ray is going to help you in something else, and that is not just injury to the chest. It may help you to show you some free air, which you're not going to see on plain abdominal film, but you're more likely to see in a chest X-ray, especially if it's an upright chest X-ray. So let's say you got a chest X-ray which is negative, it's normal, and what kind of injuries you suspect? Visceral injuries, organ injuries with this kind of mechanism. What do you suspect he may have?
Yeah, so based on this history, I suspect that could be the pancreas. Traumatic pancreatic injury.
Okay.
Crush injury,
What
duodenal injury, and then
what kind of duodenal injury think he could have? What kind of duodenal injury?
so I think it's most commonly it's a duodenal hematoma.
Correct. So you in this age group, this mechanism of injury, you're suspecting possibly two injuries. Injuries to the pancreas and injury to the duodenum. The duodenal injury most likely in these instances in this age group with this specific mechanism. It's a very specific injury and a mechanism of injury that dictates a certain type of intra-abdominal injury, and that is duodenal hematoma. For pancreatic injury, let me ask you a question that we're going to come to later on, but as far as pancreatic injury is concerned, what is the most important factor you need to determine when you have somebody who has a pancreatic injury? If I give you one thing that you need to know about with pancreatic injury, what would that be? You need to find out what? If there is a pancreatic injury, what do you need to find out? What's going to determine your management?
Yeah, so if there is a main duct injury.
Correct. Pancreatic ductal disruption. Pancreatic ductal disruption is the most important factor that you have to determine because this is going to dictate how you're going to manage these injuries, if there is a major ductal disruption or not. Now, so you do get the plain film, you don't find anything of the chest. You send the labs. Do you expect any abnormality on the labs here, even if there is pancreatic injury?
So I can see maybe serum amylase or serum lipase, but sometimes it would be in the normal range, even in a severe, even if there's a severe injuries.
And if it's high, it doesn't really indicate specifically pancreatic injury, correct?
Yes.
Okay, so after that, your clinical exam is not that revealing because there is minor tenderness, if any. the child is hemodynamically normal, and the labs are within normal limits, the chest X-ray doesn't reveal an injury, what would be your next step here?
Yeah, so the next step here, Prof, I would request a CT abdomen. That's what we do here at Trotsky.
What kind of CT you gonna
Yeah,
request?
so we do a CT scan with the IV contrast. I mean, it's the three-phase contrast. I mean, the uncontrasted, and then arterial phase, and the delayed portovenous phase.
You mentioned something about fast. You don't want to do fast?
We actually don't rely too much in our institution. The reason why that even if it is negative for a possibility of pancreatic injuries, it still does not exclude the problems.
Why?
So
why do you think it's fast is not useful? Why do you think so far, and I hope everybody's listening, guys, to that. So
yes.
far, our problem has been something that's very important, and that is we having a problem making the diagnosis of these injuries. Why do you think why do you think the clinical exam and the fast, both of them are not helpful in making the diagnosis of pancreatic and or duodenal injury? Why do you think this is?
All right. So the ultrasound itself, it's operator dependent. So
that has nothing to do with the ultrasound. Why
right.
do you think these specific organs are difficult to diagnose? Injury of these specific organs is difficult to diagnose in this early phase of evaluation. Why do you
All right.
think? Do you have an explanation?
Yeah, so the first thing is the anatomical relation of the pancreas itself. So it is
Excellent. Tell me how.
It is a retroperitoneal structure, and at the same time, ultrasound usually requested if the patient is fasting. So
No, Omar, do not get hung up on the ultrasound, fasting, and the technique and all this. You're on the right track, stick to it. And the only explanation and the single explanation of the difficulty we encounter as trauma surgeons in making the diagnosis of duodenal and pancreatic injury is the simple, basic anatomic fact that these two organs are retroperitoneal organs. So therefore, they do not show major physical and clinical signs initially on the evaluation, and the word initially should be highlighted because later on they will show clinical evidence of problems and actually severe clinical evidence of problems. But initially, in initial evaluation, in the early phase of evaluation, these two structures do not give us major, striking clinical features that would help us directing our attention to their injury.
All right.
What we just said, as a result of this, the surgeon and the traumatologist should have a very very low threshold and very high suspicion index of these injuries based only on the mechanism of injury. When you see this kind of mechanism of injury, for instance, this kind of blunt trauma, you should suspect injury to these organs.
All right.
The three mechanism of injuries that should heighten your suspicion of duodenal or pancreatic injury are blunt trauma with handlebar injury to the epigastrium, classically in children, or seatbelt mark across the abdomen with fracture of the lumbar spine, transverse fracture of the lumbar spine. If you see that, especially at the level of L1 or L2, you should definitely suspect a pancreatic injury. And number three, obviously, which is more obvious, the problem you get is more with blunt trauma. It is penetrating trauma. Gunshot wound to the abdomen, in the upper outer quadrant or the epigastrium or something like that, or a stab wound, penetrating trauma in general in this region, should definitely suspect the injuries. But you know something? The situation here, making the diagnosis here is not as challenging as blunt trauma. Because with penetrating trauma, the majority of times we go to the operating room. So, and the evaluation goes from there, as we're going to talk about in a second. But the problem arises with blunt trauma because the patient typically is hemodynamically normal. There are very minimal physical signs. The retroperitoneal ultrasound does not help me because there is no intraperitoneal fluid. You're not going to see this. No matter how expert the examiner or the ultrasonographer is, you're not going to see free fluid in the abdomen because these are retroperitoneal structures. So therefore, the majority of instances, evaluation of pancreatic and duodenal injuries, especially in blunt trauma, lies in obtaining a CT scan, as you mentioned. And we're gonna get a CT scan. You mentioned that you're gonna get a CT scan with IV contrast. Ideally, you should get a CT scan with pancreatic protocol, which is typically a thin cut CAT scan, so you wouldn't miss any injuries. But in this instance, it probably doesn't matter as much because you're not looking for tumor, but you're looking for trauma. And now, since you mentioned you are heading towards CAT scan, we will ask you, what do you expect to see on a CAT scan to help you make the diagnosis of duodenal or pancreatic injury in these instances? What do you expect to see on a CAT scan?
So on the CT scan, we can see that possibly there's an evidence of pancreatitis. I mean, in terms of fat stranding, and if it is severe, you cannot see the pancreas will enhance it. And then you might actually...
I wouldn't think the pancreas will stop enhancing 2 or 3 hours after the injury. So Omri, you really have to be careful thinking about this as pancreatitis in 2 or 3 hours. Yes, there is an item called traumatic pancreatitis. There's no question about it. There is an item. But this item takes about 12 to 24 hours to arise and take shape. And in this case, you will see evidence of pancreatitis, and it's traumatic, and it's a good indication of pancreatic injury. But you're not going to lose the pancreatic enhancement because of pancreatic necrosis in 2 or 3 hours, like you see in a necrotizing pancreatitis, as we hopefully we'll talk about one day in general surgery. You're not going to see this. So we're going back to ask you what you look for when you're standing next to the radiologist or you are looking at the CAT scan yourself. Surgical trainees and surgeons in general should be very familiar with reading CAT scans on different pathology they deal with and they treat. We should learn to a good degree, not to the expert degree, but to a good degree, how to look at and read CAT scans. So the question to you now, if you are looking at the CAT scan of the abdominal pelvis with IV contrast that you requested, can you tell me the criteria or the findings you will be looking for to make or exclude the diagnosis of pancreatic and duodenal injury?
All right. So if you start with the pancreas itself, if you can maybe actually you can find that there's a possibility of the duct disruption, but this is needs a very high expert to see it. That I'm not one of them, but you can see another associated signs like a free fluid, which is unlikely because it's a retroperitoneal structure, but you may find the fluid in the lesser sac.
Okay, that's excellent. Fluid in the lesser sac is an important finding. That's correct. Fluid in the lesser sac, free fluid in the lesser sac, and where else can you find free fluid around the pancreas? That's probably more indicative of injury than free fluid in the lesser sac. I can tell you, free fluid behind the pancreas is very indicative. Behind the pancreas, near the splenic vein. If you remember the anatomy of the of the vasculature of the pancreas. The splenic vein is almost embedded into the back wall of the pancreas, and the splenic artery is superior to the body of the pancreas and has this serpentine, wavy, like a snake thing. But the splenic vein is very intimate to the parenchyma of the pancreas. Sometimes it's actually buried in the parenchyma, or at least living in a groove in the back of the pancreas. If you see fluid behind the pancreas in the area of the splenic vein, or between the pancreas and the splenic vein, that's very indicative of an injury. Excellent. So fluid around the pancreas and in the lesser sac will raise your suspicion of pancreatic injury. What else? What else can you see?
Yeah, so it might be another, associated injury. If there is a duodenal injury, you may see actually maybe a free air, or maybe you can see an evidence of hematoma around the duodenum. So it may gives you a clue that also the nearby structure might be involved, which is the pancreas is one of them.
Excellent. By association. So you may see some retroperitoneal air behind the duodenum, and
Yes.
you may see some fluid behind the duodenum, or you may see intra-duodenum, and that will also raise your suspicion of possible pancreatic injury. So there are some of these criteria will give you an indication that there is possibly a pancreatic injury. Now, so let's say with your child, going back to your case, you do the CAT scan, and what you find is intramural hematoma in all of the duodenum, and very, very slight amount of stranding around the pancreas. No free fluid. Stranding.
All right.
Inflammatory reaction, stranding. What would be your management? The child is still hemodynamically normal. There is minimal degree of abdominal pain, and the CAT scan is otherwise unremarkable, and he doesn't have peritonitis. So, but there is stranding around the body of the pancreas.
Yeah.
What would be your management then? And I have to remind you, we are about 3 hours since the injury.
All right, so that's fine. So at this point, if the CT scan doesn't show that there is a possibility of a duct injury, major duct injury. So at this point, I still have a possibility of minor duct injury, distal duct injury. But if there is just a fat stranding and there is no free fluids around the pancreas at that point, so no, I suspect.
Omar, I want to just correct one thing.
Yes.
So, ductal injury, the word distal ductal injury still means main duct injury, because the main duct goes distally.
Yes.
Right?
Yeah.
So, but you meant minor ductal injury, because there is a main duct and there is side branch, or no ductal injury at all, right? You may not have a ductal injury, right? You may have a parenchymal injury, but no ductal injury, correct?
Yes.
So the best way to say right now, especially to the examiner, is that ductal injury, period. Okay? So you can say major ductal injury, period. Don't say distal and proximal, because that gets you in a very, gray area. So,
all right.
But so you are telling me now, or you're telling us that you, at least till now, you don't have evidence of major pancreatic duct disruption. Therefore, what you think your management is going to be at this point of this child?
Yeah, so this is maybe as you mentioned, Prof, it's a grade 1 pancreatic injury. So it's just, a close follow-up and then a clinical examination. Serial clinical examination. But for the duodenal hematoma, which is now, it depends. So if the patient doesn't have feature of a gastric outlet obstruction, he's eating, there's no other problem, so that's fine. We can actually treat this conservatively. Now, if there is an indication for surgery, that might be an indication for intervention simultaneously. But at this point, I wouldn't urge this patient to theater. So I just admit him to the ward and then serial examination and observation.
Oh, excellent. So you're going to admit them, observe him, correct?
Yeah.
Okay. Next morning, he's in increasing abdominal pain, and his abdomen is more tender, but more importantly, he's having more abdominal pain. Definitely the abdominal pain is increasing. And
Good.
he vomited once. When he tried to feed him, it didn't go down well.
Good. So here I have two different.
What would be your action then?
Yes, my action, I would actually prepare this patient to the OR. So I have two differential diagnoses here. It could be, as we put in the first thing, the differential diagnosis of a duct injury, of a pancreatic duct injury, or we actually missed the hollow viscous injury, which is the duodenum, one of them.
Okay, so you want to operate on a child?
Yes.
Okay. His parents don't want you to operate on their child, and they're asking if there is any tests he can do to make sure he actually needs the operation.
All right, so I can offer MRCP, which can actually gives me more sensitivity about the pancreatic duct itself. But if it's a duodenal issues, so that's going to be, it need to be sorted out intraoperatively.
Right, so you're going to do MRCP?
Yes.
Okay. MRCP shows major pancreatic ductal disruption just to the left of the SMA.
All right, so the management
distal to the neck of the pancreas.
Yeah, so this is should be treated by a distal pancreatectomy or left side pancreatectomy.
Okay.
And a drain.
So you still want to operate on the child?
Yes, Prof.
So the parents are kind of agreeing. However, they do have questions, and they're saying, is there any possibility to treat this without an operation?
There is something about the pancreatic stent, but in our setting, Prof, we don't treat the traumatic pancreatic disruption endoscopically unless it's going to be a very proximal or, I mean, yeah, if it's proximal, that's fine. You may do a pancreatic stent, but to reach at that site and to apply stent, I think it's a bit challenging. So,
well, they're not really talking, but they're very well educated parents, and they're asking, okay, what if you don't operate? What do you think is going to happen to my child?
Yeah. So if I don't operate, so this patient will have a lot of complications, which is, I can list it for you, Prof, but he's going to have a pancreatic aside.
We are talking about consequences of non-operative management of this kind of injury if someone decides to pursue that route, or if the injury was missed. Can you tell me the possible consequences of this?
Yeah, so the complications here, it could be a pancreatic ascites or pancreatic fistula, and then with a whole nutritional and septic complications behind it.
Okay, anything else?
So it could be, I mean, vascular complications like splenic artery.
Yeah, it doesn't have vascular injury, but so pancreatic leakage and fistula and pancreatic abscess, right? Infection, right?
Yeah.
Okay, so the parents are convinced and they agreed for you to go to the operating room. How are you going to conduct this operation?
All right, so once I get a consent from the family and the patient himself, so I'll take the patient to theater after a preoperative preparation from IV fluids and IV antibiotics, analgesia. And then I think you mentioned that the patient is vomiting. So I think I should put an NGT and the urine catheter at this point. So I'll take the patient to theater. I'll put the patient on a supine position after discussion with the anesthetist about the plan at WHO. And then I mean, intraoperatively, it's going to be driving from the chest to the thigh, in case that you might have vascular issues. So after checklist being done, midline laboratory. Sorry, he's a 19-year-old. So I think it's I think I'm gonna use.
No. He's only 9.
Oh, sorry, nine. Yeah. So sorry, Prof. So so make sure that the patient is not hypothermic. I would start with the transverse abdominal incision. Now I would assist the abdomen, and then check for the 3B signs. So any blood.
Omar, do you do transverse abdominal incision for acute trauma?
To be honest, Prof, I haven't operated myself on a patient, or I mean on a pediatric. But yes, we do sometimes a transverse abdominal incision.
Okay. All right. Okay. So you're in the abdomen. Okay. What you gonna do now?
Yeah. So you assess the abdominal organs, check the whole intestine, and then after that, I have a preoperative diagnosis. So I have a major duct disruption. So I will open the lesser sac by retracting the stomach upward and then the colon downward, and then entering the lesser sac by dissecting the greater omentum close to the colon. And then in the lesser sac, I will look for the
What do you have to be careful with when you transecting the gastrocolic ligament,
yes,
otherwise known as the greater omentum?
Yes.
Any vessel injury that you should avoid?
Yes, bro. So the middle colic vein, it should be actually very precisely looked for.
No, the middle colic vasculature, arterial vein, have nothing to do with the gastrocolic ligament or the greater omentum. They have everything to do with the transverse mesocolon, and you're not there yet. In opening the lesser sac, through incising the gastrocolic ligament, otherwise known as the greater omentum,
yes.
What vessel could you possibly injure there?
So the gastroepiploic, but that's close to the curvature.
The gastroepiploic. Therefore, you're going to go distal, as you said, closer to the colon, right?
Yes.
After incising that, and how are you going to approach the pancreas? How are you going to see the pancreas?
Yeah, so once you are in the lesser sac, you can actually retract the stomach cephalad, and then you can find that there is some congenital bands between the stomach and the pancreas. So you can transect it by the energetic device, and then you can actually look and see the pancreas. So you can see if there's any possible signs of pancreatic injury by looking for the 3Bs, which is blood, bile, or bubbles, I mean air. So by doing this, I mean by finding one of them, so this is an indication of that most likely there is a pancreatic or a duodenal injury.
Okay,
so
how are you going to explore the duodenum?
All right, so the duodenum, I actually do a cauterization. So I would do I don't think it's an indication for a full cauterization, for extended cauterization here, but I think if I can do a cauterization, it's to dissect the avascular plan of the duodenum, which is extending from D2 to D3.
How many portions does the duodenum have, Omar?
Yeah, 4.
Can you tell me how you're going to see these 4 portions? Do you need to explore these 4 portions in this case? To make sure they're not injured?
Yes, I think so, Prof.
Excellent. Can you tell me how you're going to do that? The question, to be precise, how are you going to interrogate, investigate, and explore the entire duodenum in a blunt trauma case to make sure there is or there isn't an injury?
All right. So I'll start from the top. So from the hepatoduodenal ligament. So which is the extension of the lesser sac. The lesser the lesser omentum. So you actually identify the D1 day and then transect the gastro, I mean the
What are the portions that are easy to see and feel and everything? What are they? Once
yeah,
it's
so
recognized.
D1, D2, and then the proximal part of D3. That's all what.
And actually D3, okay? So if you extend the cauterization, you'll be very well able to see and feel. See
Yes.
and feel. D1, D2, D3. Your problem is D4. How can you find out if there is a D4 injury or not?
So at this point, I have to transect the ligament of Treitz.
Okay, so you incise the ligament of Treitz, and that will mobilize the DJ junction, duodenal junction. Okay, right? You're gonna divide this attachment so the DJ junction is mobilized. Okay, I'm with you. And what? Okay, keep going.
All right. And then, yeah, so you can do your cauterization by identifying the avascular plane at the lateral edges of D2. And then you can actually feel it by your left hand while you're dissecting. And then you can feel also the pancreas behind it. In D2, you need to be very careful so that you're not injured the...
No, we're still on D4. We're not done with D4. We've done D1, D2, D3. Tell me how you're gonna be comfortable saying that D4 is okay. You said that we're gonna divide the ligament of Treitz. Okay, we've done that. And now what?
Yeah, so I think I'm gonna do an extended cauterization here.
So you're gonna extend the cauterization almost to be in front of the aorta, right? On the left side, right?
Yes, at the insertion of the left renal vein to the IVC.
Yeah, on the left side. And now, how are you gonna? You're probably gonna be able to feel the fourth portion now, right?
Yes.
Okay, and you're gonna feel it bimanually, right? So the left hand, which did the extended cauterization, is gonna be the fingers, the index and middle fingers are gonna be behind the third portion of duodenum, reaching out to the fourth portion, and the thumb is gonna be in front. That's from the left side. From the right side, after you divided the ligament of Treitz, your two fingers and the thumb also gonna come. These two are gonna meet behind the fourth portion. You're gonna connect the right and left side of the abdomen behind the fourth portion of duodenum. That way, these fingers are gonna touch. You almost like at the time of dividing the proximal jejunum in a Whipple operation and sweeping this specimen after you divide the jejunum, sweeping it behind the SMA to get it to the right side to complete your pancreatic duodenectomy. So you're obviously not going to do that here, but these two fingers are going to touch and you're going to feel, and that will ensure that the fourth portion is not divided. Now, you're going to do that, and what you see in your child, 9-year-old boy, you're going to see that there is a hematoma in the wall of the duodenum, but covered by serosa. There is no injury, there is no bile, but you do see transected pancreatic parenchyma and ductal disruption, just like the CT scan showed, or just like the MRCP showed, to the left of the SMA. What you're gonna do now?
So at this point, Prof, I've made a decision to do a distal pancreatectomy.
How are you gonna?
Yeah, so at this point, I actually make a actually, Prof, I'm not sure if there's any rule for a skin preserving for the spleen preserving in this at this point, but I think it's a good option.
What's gonna be the determining factor if you want to preserve the spleen or not?
If there is no other intra-abdominal organ injuries and the patient is hemodynamically stable.
That's the most important thing, hemodynamic stability of the patient. Okay, the patient is stable. Let's assume that you're gonna do pancreatic preserving. How are you gonna do that? Or not? How are you gonna do distal pancreatectomy?
Yeah, so I think at this point, So my plan is gonna be removal of the to be honest, Prof, I haven't done a spleen preserving.
Okay, that's very fair actually to see on your exam actually, and I think that's the best thing to tell the examiner, I'm not familiar with splenic preservation and I'd like to take the spleen. That's perfectly acceptable. The examiner should not really be upset or be against you in anything. The thing that really looks bad on the test, when you make stuff up, when you start saying stuff that has no rule or anything. But if you say, I haven't seen this procedure, but I can describe it, something like that, it always works well. Fine, you're gonna take the spleen. Tell us how we're gonna proceed with the operation.
Yeah, so actually, I'm gonna lift the spleen, from at the transected area. And then I actually will identify the splenic vessels, which is going to be carefully isolated. At this point, I'm going to transect it, so I don't need to do a spleen preserving. So I'm going to identify the splenic vessels, transect them, and then I'm going to dissect up to the splenic hilum. So I'm going to remove the whole distal pancreas with the spleen. I don't think it's going to be an issue there, but I'm just gonna overzone my my transection site at the proximal.
How are you gonna divide the pancreas and the vessels?
So I'm gonna actually I'm gonna I'm gonna suture ligate the two main pancreatic vessels or the major pancreatic.
Splenic vessels, you mean?
Yeah, the splenic vessel as well as the pancreatic vessels, the two arcades.
There's not much of pancreatic vessels. The pancreas gets fed from the splenic artery and drained by the splenic vein. There's pancreatic magna, which is a big vessel, but you're probably not going to encounter that. It's a little bit distal, but you need to deal with the splenic artery and the vein, right?
Yes.
Okay. How are we going to do that?
Yeah, so the splenic artery is going to be on the anterior superior surface of the pancreas, and the splenic vein. And the splenic vein is going to be on the posterior surface of the pancreas.
Sure. Yeah. How are we going to control them? Tell us.
Yeah. So that's fine. So once I identify the splenic artery, I will put it on the two artery clamp, and then suture ligate, double ligation, and then transect the artery on the anterior superior surface. Once I transect the pancreas, I can see the posterior, the splenic vein, which it should be a double ligated and then transected.
Okay, how are we going to deal with the proximal pancreatic parenchyma? And
so I'm going to overzone the stump. So I'm not sure if there is any evidence behind decreased pancreatic leak, but that's what we do routinely.
You mean you're not going to? Can you just leave it alone, or?
No, we're gonna overzone. We're gonna actually put a suture on the parenchymal edge.
Right. Anything else you wanna? Any other way you wanna divide the pancreatic parenchyma or whatever left of it?
Do you mean using of stapler, Prof?
Right. What kind of stapler?
Yeah. So I think I'm gonna use the vascular stapler, which is the white one, the largest one.
Okay, so you can use a stapler for
one.
And you can actually use a stapler to take the whole thing, just to let you know that. If you are going to use a vascular stapler, which is a white load, I'm glad you guys on top of all this, you can use a white load vascular stapler. You can take the whole thing, parenchyma, artery, vein, everything, almost like doing elective distal pancreatectomy, laparoscopic or something like that. You can do the vessels separately, but in a trauma case, if I'm in this case, I'm getting a stapler with white load, I'm firing across everything, right where the injury happened. And I can reinforce the pancreatic parenchyma with some sutures if need be, but I'll definitely rely on the staple line. Right, you do that, and anything else you want to do now? The specimen is out. Do you want to do anything else?
Yeah, I'm going to leave a drain at this point, which is going to be
Okay. Anything else you want to do after surgery? surgery is done, how are you going to take care of him after the operation?
Yeah, so after the operation, so it's going to be a routine post-operative monitoring in terms of vitals.
He had a duodenal hematoma, so you're going to let him eat or no? Or why not?
Oh, yes. Oh, yes. So I've forgotten that part. So actually, at this point, I'm going to pass the nasojejunal feed just in case that this patient might not have, it may take 7 to 10 days to resolve. So I think I'm going to pass the nasojejunal.
You do that and he does well and he starts taking PO and you take the tube out, let's say day 5 or 6, and he's now eating. Your drain is putting out 500 cc's of clear fluid.
All right. So at day 3,
it has been a week.
Yeah. So yes, Prof. So we actually do a fluid lipase at day 3, and then see if it is more than 3 times the normal value. I mean, more than 60.
We do amylase actually. So you mean pancreatic amylase in the 3?
Yes, yeah, amylase. Sorry.
Okay.
So
it's 15,000.
Yeah. So So this patient's got a pancreatic fistula.
How are you going to do that now?
Yeah, so it depends on the volume. So the volume you mentioned, Prof, it's 500 a day. Yes. So yeah, so at this point, I'm gonna keep the drain, and then I will optimize this patient's nutrition. So at this point, I will try to bypass the pancreatic. Sorry, I should bypass. I will try to bypass the ambula. So I want to put the pancreas in a resting position at the moment, and then I will feed the patients entirely through the nasojejunal feed.
Well, the nasojejunal feed is out. He was eating.
Yeah, so I will try to insert it, and then if I fail, I will actually ask the endoscopist to pass it. If that's successful, that's fine.
You're not going to let him eat.
Yeah, this patient should be an MPO at the moment because I don't want to.
That's fine. How long and what's your plan? Now we're about 10 days and there's about 300 cc's out every day.
Yeah, so TBN also is a good option, but if it's
been 12 days now and 350 cc's out. And the parents are getting a little bit frustrated.
All right. So, yeah, so from the enteral point of view, we sorted sepsis is okay. Now, ERCP, I don't think it's going to be, yeah, I think it's fine if they can actually plug the pancreatic duct, but...
if you can do what, sorry? ERCP, if you can do what?
They can actually intubate the pancreatic duct and then maybe can plug it or put a stent, but actually stent is not going to work. I'm not stenting. Yeah.
Why?
Yeah, so actually I'm trying to drain the pancreas. So so if I do an ERCP just to drain the ambula, I mean, drain the pancreatic juice, that would be fine. But I don't think I'm going to put any stent or any.
Okay, what if you don't want to do stent? Can you do something else with the ERCP to solve this problem? Now it's been 15 days and there's about
So I actually, so Prof, I think we're gonna do do a sphincterotomy and then apply a stent so that we can drain the pancreatic juice and then decrease pressure.
100%. This is gonna fix the problem.
Yes.
This is gonna fix your problem. If it goes that far and you're still having persistent pancreatic fistula, this is the easiest pancreatic leak that's gonna close because you have a healthy pancreas, you have you don't have an infection, as I said. We forgot to get the CAT scan, but you should get a CAT scan. And all you need to do, if it goes that far out and you're 2 weeks out, you need to get an ERCP, sphincterotomy minus plus stenting. All you may need is pancreatic sphincterotomy. And that will take the back pressure off the pancreatic duct And the pancreas will drain in the path of least resistance, which is now the second portion of duodenum. So you basically disrupting the pancreatic duct sphincter to create the path of least resistance through the pancreatic duct proximally into the duodenum, into the ampulla, so your distal fistula can heal. As long as there is no obstruction in the pancreas, in the proximal pancreatic specimen, and there shouldn't be, this is a healthy 9-year-old pancreas. There's nothing wrong with it. There is no chronic pancreatitis. There is no stricture. This will heal. It will heal. So in order to help yourself a little bit more, because it has been 2 weeks so far, is to request an ERCP, and the ERCPist is going to do sphincterotomy, take the back pressure of the pancreatic duct, and help you out. Right. So, we are going to do 2 cases as we promised. We're going to move on to the second case, and then we're going to have a couple of slides to go over. The second case is a little bit different. This is an adult who got stabbed in the epigastrium just to the right side of the abdomen, in the subcostal region, in the right side of the abdomen, upper abdomen, single stab wound, was in fighting with a dispute with some people, and he got stabbed once with a long knife in the upper abdomen. He is in trauma bay for your evaluation, and he is hemodynamically normal. His blood pressure is 130/70. He is tachycardic. He's a young man. He's 25 years old. He's tachycardic to 130. He's 100% saturation on the pulse oximetry on room air. And you see a single stab wound in the epigastrium to the right of the midline. I'm going to approach this patient.
Sorry, Prof, would you like me to continue, or can I ask one of the Khartoum registrar?
Yeah, well, let's get somebody else.
Thank you so much, Prof. I just want to give two opportunity.
Dr. Muhammad Ali.
Assalamu
alaikum. Go ahead. Have you heard the scenario?
Yeah, hemodynamically stable adult patient with a single stab to the right of the midline.
In the epigastrium, correct.
Yeah. Simply, I'll follow the protocol first of the ATLS. Admit the patient, airway, bleeding, circulation. But you mentioned airway is fine. Bleeding definitely will be fine. The circulation, because he's tachycardic, I have to insert 2 wide bore cannulae, draw blood for baseline investigation, prepare blood for this patient. Then I have to do 2 X-rays recommended for those patients. Chest X-ray and pelvic X-ray. No, this is a penetrating trauma, not blood. I'm sorry. I have to assess because it's
X-ray. Are you going to do a chest X-ray or no?
no, because this is penetrating trauma.
You don't think you can get diaphragm in this area?
Yeah, I can get a diaphragmatic injury.
Right. You don't think you can get pneumothorax then?
Yeah, chest X-ray is mandatory. Pelvic X-ray, I don't think.
Correct. So you are going to get a chest X-ray, right?
Yeah, to exclude chest injury, diaphragmatic injury.
Okay. Well, the chest X-ray is not going to show diaphragmatic injury, but it'll show pneumothorax. And this X-ray is normal. You got a chest X-ray, it's normal. Anything else you want to do now?
I have to do a FAST scan first.
Okay, and the FAST doesn't show fluid in the abdomen.
Maybe local exploration of the wound may help.
So let me ask you something, Muhammad. Let me ask you something. Penetrating trauma in this region. Can you tell me the organs he's suspecting injury of?
To the right of the midline, duodenal injury.
Okay, what else?
Major vessel injury, aorta, and IVC.
IVC and what else?
If it's long, you said it's long knife, can to extend to retroperitoneal organs like kidney, gallbladder, liver injury.
No, we're on the vessels still. You said duodenum and vascular injury. What kind of vascular injury?
Vascular injury, major vessel injury, maybe on the right side to the epigastrium, abdominal aorta, IVC.
Anything else?
Biliary tree,
No, vessels. Anything else?
vessels, portal vein.
Correct. So you're suspecting portal vein, superior mesenteric vessels, IVC, minus plus aorta, but let's say on the right side, that's what we're suspecting. So duodenal and vascular injury. What else?
Duodenal injury could be isolated with another organs, head of pancreas,
So
biliary
pancreas,
tree,
pancreas
biliary,
and biliary tree. Anything else?
vessels that crossing the transpyloric plane at this point, left renal vessels,
Okay. So left.
distal stomach.
Okay, good. So you have a plan of what could possibly be injured here. Colon, right? Transverse colon?
Yeah.
Right. So it was a long knife. So you said, where are we going to go now? You said you're going to do local wound exploration?
No, it's penetrating, but the patient is hemodynamically stable. Give me time for CT scan.
Okay.
But
So
if it,
let me ask you, okay. You're going to do a CT scan. What kind of CAT scan?
CT scan with oral IV contrast?
You're going to use oral contrast?
No, IV contrast.
IV only, right? We usually don't
Yeah.
use oral contrast in trauma, right? Usually.
Yeah. Yeah.
Okay. So you get the CT scan with oral contrast, and you do find fluid collection behind the duodenum and free air in the retroperitoneum.
Yeah, this is most probably due to duodenal injury, and I have to grade more with the CT. Is it isolated duodenal injury or with biliary pancreatic complex?
You cannot tell. The CAT scan is not going to be able to tell you that. So, but you do the CAT scan, there is fluid collection in the retroperitoneum, retroduodenal area with free air in the retroperitoneum.
This is most probably will be due to the duodenal injury.
But what you're going to do now?
Sorry, Prof, can you ask me again?
What's your plan now? What's your plan?
If the patient is still a stable patient under resuscitation, I can D-line it. I can request MRCP before go to surgery to see if there is any biliary system involvement or any disruption on the pancreatic tissue, because this pancreatic duodenal injury will be more complex and the management will differ.
So let's say the MRCP doesn't show biliary or pancreatic. You're not going to go to the operating room? Are you going to the operating room or no?
No. Yeah, I'm going. I'll go to the operating room.
So does it matter if you need to know injury to the biliary tree or the pancreas if you go into the operating room?
It doesn't matter, but if the patient is stable and give me a lot more time and it's quick, investigation can be made, it will give me a clue, pre-operative, to be safe, to decide whether to go for, according to the grade of the duodenal injury, and is it a simple duodenal injury isolated or associated with other organ injury, pancreatic or biliary, because the management will differ.
Let's say the MRCP, which is MRI, of course, it's 1 o'clock in the morning and it's not available.
Now I'll go for the operating room, and intraoperative.
So you are in the operating room. Tell us how you're going to approach that.
First, scrubbing the patient from the chest up to thigh, supine position, discussing the anesthetics, blood prepared, then a midline laparotomy will be done. Then I have to do formal laparotomy. If any fluid seen, other associated injuries, it has to be excluded. Formal laparotomy to expose.
How are we going to expose the duodenum to check the injury?
The duodenum, I have, there are many ways, but the classical way, lateral coherization of the duodenum from right to left side to expose second part. I have to release the hepatoduodenal ligament to see the first part clearly, because the first inch of the first part will be retroperitoneal. So I have to take that ligament, first, second, and third, up to the vessels.
Okay, so let's say you do all this and you mobilize also the hepatic flexure in order to be able to do that. And what you see is you see the injury to the junction of the first and second portion of duodenum that encompasses about 50% of the circumference of the duodenum. And there is also about 1 centimeter loss in the wall of the anterior duodenum here in this area. And of course, there's bile coming out from this area. How are we going to handle this injury? You check the vessels, the IVC looks fine, there is no bleeding, there is no hematoma. So how are we going to handle this kind of duodenal injury?
Definitely without duct injury, this is, it will be grade 2. Because on the grade, it's grade 3, duodenal injury. Primary repair of the defects.
How are you going to?
Sorry, Prof.
How are you going to do the primary repair?
Transverse. The recommended way to do transverse, the anterior laceration, it has to be transversely sutured.
What are you going to use?
Non-absorbable suture. Non-absorbable small suture.
You're going to use non-absorbable single layer?
No, absorbable, I mean. Sorry.
Single layer?
Absorbable double layer.
And you're going to use absorbable for both layers?
Honestly, Prof, this is different from center to center. Some people, they do the repair interruptedly, transverse with omental batch, and some centers, they do double layered. One is continuous, the second layer to overcome the first layer by doing interrupting.
Okay, so let's say you try and do this, you try and take suture to close it, and doesn't come together, and the sutures are cutting through because there is tissue loss. What should you do now?
Tissue loss, transect this part, and to do bypass, I have to bypass the anatomy.
What do you mean transect this part? How are you going to transect the second portion?
The injury you said between first and second part, I'll do pyloric preserving resection to close the duodenum.
No, just a second. What do you mean pyloric preserving? Pyloric preserving what? What resection?
You said the injury between first and second part.
Yeah, just as the first portion coming, just as D1 coming to D2, almost like in this area here. And there is tissue loss, you cannot really close it primarily. How are we going to handle this injury?
I'll close the distal part, and I can do gastrojejunostomy with the stump closure. How
are you going to close the distal part? What do you mean close the distal part?
50%, you said 50% laceration. I'll cut this part, refine the edges between the proximal and the distal part, between the first and the second part. I'll close the proximal and distal part.
So you're gonna,
distal part is the duodenal.
we are going to transect the duodenum where the injury is next to the, remember, inside the C here, this is the head of the pancreas. So you're gonna go and transect that, close the proximal and close the distal. That's what you're gonna do. I just wanna make sure I heard you right.
I think this is grade 3. Grade 3 it has two parts, proximal to ampulla, either distal to ampulla or verter. Proximal to ampulla, I can do primary repair, or I can do atherectomy plus gastrojejunostomy.
Muhammad, you cannot do primary repair. The tissue, there's tissue loss. You cannot get it together.
I can do atherectomy or distal gastrectomy with bypass, gastrojejunostomy.
Just tell me how you're going to handle that duodenum area with the tissue loss. How are you going to handle that?
I don't know, bro.
So you said distal gastrectomy?
Yeah, atherectomy or distal gastrectomy plus bypass, gastrojejunostomy with closure of the duodenal stump.
But there is bile that's going to come out. Distal gastrectomy, taking the stomach out, it's not going to, there's going to be bile coming out from the open duodenum. You're going to leave it open?
No, I'll close it.
Again, how are you going to close it?
Prof, I'll transect at the site of the injury because it's more than 50%. Then I have proximal and distal part. I'll close the distal part with 2 layers with omental batching. Then I can do atherectomy to resect the antrum with the first part of the duodenum with the preservation of the surrounding anatomy with good exposure to the distal CBD. And then I can do bypass. Or I can do, if it's around 50% with tissue loss, I can do jejunal batching.
Yes, now we're talking now. I'm not sure about transecting the duodenum at the injury and closing proximal and distal, and now we shut the duodenum off completely and doing an atherectomy. I'm not sure about that. So tell me about this duodenal patch. How are you going to do that?
I don't know.
Okay. Anyone can help us, guys? How are we going to get ourselves out of this problem? We have a major duodenal injury, and some tissue loss that I'm not able to close. How can I get myself out of this problem? Anyone, guys, can help us?
Can I do Rho and Y?
Yeah, sure, you can, but Rho and Y of what? What do you mean?
Rho and Y, Rho and Y, I think, and let me think. Rho and Y duodenal jejunostomy.
Rho and Y of the jejunum. So you can bring up a loop of jejunum up there, and you either have to anastomose it. You sometimes don't even have to anastomose it to the duodenum. You can use it as a jejunal patch, jejunal serosal patch. You bring a loop up, whether Rho or not, you can do a Rho for sure, and either anastomose it to this area. But if you don't want to, sometimes you can suture. You don't have to open the jejunum. You can use the jejunum to put it as a patch onto the area of the duodenum where there is a tissue loss, and you suture around it. You can use like a 3/0 silk or something and suture that. Use the jejunum as a patch, jejunal patch of the area of the duodenum. That's where there is tissue loss. This is an option. The other option is you can bring a chunk of omentum, even if you cannot close the duodenum hole itself, because it's not going to take sutures and there is some area of tissue loss here. You can bring a chunk of omentum and put it on that and suture it around, omental patch. You can do that too. You don't have to close the duodenum. Now, having done these two, you are going to add adjunct, adjuvant, supporting measures to your repair of the duodenum, because you have a major duodenal injury. How you can support that? You can support it in many different ways. There are mandatory things you should do, and one of them is intraduodenal decompression of the pressure. So after you put your omental patch, after you put your serosal patch, even if you're able to close the duodenum primarily, it is very recommended that you decompress the duodenum intraluminally, take the pressure down, and you can do that in two ways. You can pass a nasoenteric tube, nasojejunal tube from the nose and thread it down to the proximal jejunum, and you decompress the duodenum that way. Better is you do a retrograde duodenal tube from the distal, from the proximal jejunum, and thread it up into the duodenum for decompression. Some people do a lateral duodenostomy, which is not really that recommending. You're gonna leave a subhepatic drain to drain this area just in case your repair doesn't succeed. All these are adjunct methods. And another important addition is that you could resort to is pyloric exclusion method, which is great. After you put your omentum or jejunal patch on the duodenum, you can do a gastrotomy, open the pyloric area or distal antrum, grab the pylorus with an Alice clamp, deliver it like you do with your socks. You know, you put your hand in the socks, grab the pylorus out, put a purse string Prolene, non-absorbable suture. Purse string, shut the pylorus down, drop it in, then through your gastrostomy tube, gastrotomy site, I'm sorry, you're gonna do a gastro J. So what you've done is you bypass the area of injury, you have a gastrojejunostomy, you shut down the pylorus, and you shoved omentum or jejunal serosa on the area of injury. You drain the duodenum, the subhepatic area, just in case you get a leak. You also may or may not have decompressed the duodenum intraluminally. Before you leave the operating room, you're gonna do one important thing, and that is a distal feeding jejunostomy. You're gonna put a feeding jejunostomy, just in case the duodenal repair fell apart. You don't have to rely on TPN. You can use enteral feeding through the jejunostomy tube. Before you leave, you have to check all the vessels we told you they're okay. You may find pancreatic injury. If it's not major as the one that we had with Omar, if it's a grade 1 or 2 pancreatic parenchymal injury, you can put a drain only on the top of the pancreas. That will drain the pancreatic juice and that should get you out of this. What we just described is a repair of major duodenal injury. The same principles apply for general surgery when you have a giant perforated duodenal ulcer that's not coming together to close. Use the same principles. Omental plug, jejunal serosal patch, pyloric exclusion, periduodenal drainage, intraduodenal decompression, gastro J, feeding jejunostomy. It's almost a standard package you're going to deliver if you have a major duodenal injury, or if you have a giant duodenal ulcer that you cannot really treat by simple closure. So we're just gonna go quickly in 10 minutes or so over just a couple of slides to basically catch up and recap on what we talked about in some areas. So as we just mentioned, that because of the retroperitoneal locations and because of the anatomic location, always search, as we asked Muhammad, duodenal, vascular, pancreatic. It's a very crowded anatomic area, guys. Very crowded anatomic areas. So suspect other injuries, very important. These are the challenges the challenges that we have with these kind of duodenal and the pancreatic injury. So the majority of mortality here, not surprising, is due to hemorrhage. See what's around you: IVC, portal vein, SMA, SMV, aorta. It's a very crowded area. So we're not surprised that the majority of mortality in these cases is due to associated vascular injury and hemorrhage, right? So always remember that control of hemorrhage is really important. So as any other area in trauma where we have priorities and damage control applies here, the same thing. When you get this kind of injury, always remember that. Next slide, guys, 1 through 4, 1, 2, 3, 4. Any trainee sitting for the exam, dealing with trauma, this doesn't only apply to pancreatic and duodenal injury, no. This applies to any trauma case. Please, guys, remember that. Any trauma case, these 4 priorities, principles, use them, apply them. Number 1, control hemorrhage from major vessels. Number 2, look for solid organs, liver, spleen, kidney. Number 3, pay attention to succus or stool. Number 4, and after that, you stabilize any major bony injuries if there is any. In that order of priorities. So, with duodenal and pancreatic injuries in a crowded area where these priorities, priorities of that really are very well illustrated. Major hemorrhage, solid organs, succus, stool, and bile come after that, and bones come in the end. So the classic scenario here is a child that we talked about with Omar, or the penetrating trauma. These are the classic scenarios where you see this. As we just talked, high index of suspicion. These injuries are very deceptive, guys. They don't show well initially. Think and suspect them so you can make the diagnosis and don't miss them. Rupture of duodenum is not gonna give you that much pain initially. It's not gonna give you fever or white cell count. This is gonna happen if you miss it, and 48 hours later, and the die is cast, as we say, and you have a problem then. You wanna make the diagnosis where there are minimal or no injuries at all, okay? The pancreas and duodenum are located retroperitoneally, so physical examination actually in the first 24 hours may be very deceptive. Please remember this slide, guys. Physical examination may be very deceptive early on. These are retroperitoneal structures. Don't expect major signs. No peritoneal signs in the retroperitoneal organs. The same thing. Even hemorrhage may be tamponaded in the retroperitoneum, and it may not give you major hemodynamic instability. Do you see how deceptive these injuries are? Think about them as long as the mechanism is consistent with these injuries. So in patients with minimal abdominal findings, CAT scan is usually used. So examination should always be performed during any abdominal exploration for blunt trauma. If you're going in the abdomen for any blunt trauma, for a small bowel injury, liver, kidney, please check the duodenum. This is the deceptive organ that can sit in the back in the retroperitoneum, and you have to search it to make the diagnosis. Fast, as we talked with Omar, doesn't help you much. Not because the examiner is bad in doing the fast and not good. No, because there is no fluid. It's not gonna show much. Again, all go back to the fact that these are retroperitoneal structures. So CT scan in a stable patient, we rely on CT scan. In unstable patient, or blunt trauma or penetrating trauma, we rely on the abdominal exploration. So the 2 methods, to recap, guys, and summarize, the 2 methods to diagnose duodenal and pancreatic injuries are 2 things. Stable patient, blunt trauma, CAT scan. Minus plus MRCP for ductal injury later on. Unstable patient and penetrating trauma, operating room. These are the two methods that we're going to use to make this diagnosis. As we talked with Omar, there's a table here with what we can see on a CAT scan to make the diagnosis. Look at the diagnostic findings. Forget the suggestives. Look at the right side of the screen. Parenchymal laceration or hematoma. Transection of the parenchyma with fluid in the lesser sac. Disruption of the pancreatic head. Diffuse swelling consistent with post-traumatic pancreatitis. All this, the last line, guys, you're going to see that 24 hours or 48 hours later, but you will see it for a missed injury. When you see that, you have a major pancreatic injury. Okay? So because of the position of the duodenum, laparoscopy is not good either. And it's good that we didn't hear it today, actually. Nobody brought this up, that we can do diagnostic laparoscopy to look at duodenal pancreatic injury. Not good. It's not going to help you. It isn't fast. It's not going to help you. Do you see our challenges, guys? Physical exam doesn't help you much. Fast doesn't help you much. Laparoscopy doesn't help you much. You're really very restricted in what you have to make the diagnosis in these injuries. Always remember, CAT scan, stable trauma, blunt trauma, and OR, unstable and penetrating trauma patient. Surgical treatment, operative assessment of the duodenum. Here we go. This is what we talked about with Omar, how we can explore the entire duodenum from the first portion to the left portion, to the fourth portion, behind from the right to the left and the fingers meeting. That's exactly what this says. So you're going to explore that, identify any injury, pancreatic duct, portal vein, vena cava, superior mesenteric artery. Just we talked with Muhammad when in the case of penetrating trauma, how you need to identify all this. Intramural hematoma, if found preoperatively, as in the case of Omar, you can't leave it alone. But preoperatively, but intraoperatively, if you're in the abdomen and you find duodenal hematoma, you really have to explore the entire retroperitoneum to make sure that first there's no hole in the duodenum, and also there's no associated injury of the pancreas. You always leave a drain in a duodenal injury. Decompress, as we just talked with nasogastric tube from above. You can also do a nasoduodenal tube through the pylorus to decompress. And this is better than the old one, the approach for lateral duodenostomy. You don't really need to make further holes in the duodenum to do that. Avoid the temptation to perform trauma Whipple. Do not do trauma Whipple, guys. If you really have to do a trauma Whipple, it's in a very bad situation. You're probably going to lose this patient. If you find, and so what you do then? If you find the injury that severe, really severe, control the vasculature, portal vein. You can ligate the portal vein, by the way. You can ligate it. People get occluded portal vein or portal hypertension all the time. You can occlude the portal vein, repair the IVC, repair the aorta, control the vessels. And you see the pancreatic head is disrupted, dismantled. Do damage control. The patient now stable, pack, go to ICU, stabilize the patient, come back. You may have more help. So you can have two sets of eyes. You can examine and see what you have. 24, 48 hours later, fine. If you have to do a Whipple, then maybe, but do not do a Whipple 1 o'clock in the morning, fresh on a trauma patient. So consider feeding surgical duodenostomy, as we talked about, which is really important. Here is some pictures of the approach of that. You see how right medial rotation of the viscera, it exposes all this. You see the cockerization of the duodenum. See how the aorta extended cockerization and extended right medial rotation of the viscera. See how the small bowel all on the right, and then the colon. You can see the IVC is exposed, that even the aorta is exposed, and duodenum very well visualized here. Picture of pyloric exclusion that we described with Omar. You can see that here is the duodenal repair transverse fashion. Here is the pylorus open. See how the sutures inside the pylorus, the purse string or the sutures, these are permanent sutures. They're gonna open up. How they open up, who knows, you know, but it does open up, and then you perform your gastrojejunostomy. And here is what we talked about with Muhammad, how we expose the pancreas. See that gastrocolic omentum or greater curvature is transected, stomach is up, you can see the spleen, you have the entire body of the pancreas, colon down, stomach up, the pancreas is exposed. Thank you guys, we'll take any comments or questions.
Thank you, Professor Jamal, for making this challenging type of trauma very clear and simple to diagnose and manage for the registrars. And the floor is open for any comments and questions, please.
Professor?
Yes, sir.
It's Muhammad again. I just have two questions.
Yes.
On the first case of the pancreatic injury, if the patient is stable, there is any way to put a stent on the pancreatic to stent the pancreatic duct?
You mean not,
By ERCP?
yeah, non-operative management, you mean?
Yeah, before to go to the operation.
Yeah,
If I have time for stenting.
Sure, I'm with you. We talked with Omar about this, and we said that is there any role of non-operative management? And the answer to you, Muhammad, actually, no, because it's tempting. The child is doing fine. Why can I not sit on this? You're gonna have a lot of complications. Major pancreatic ductal disruption should not be treated non-operatively. It's fraught with complications of traumatic pancreatitis, infected pancreatic necrosis, pancreatic fistula, pancreatic ascites, sepsis. So that's why this kind of injury is always treated operatively. The role of ERCP, that's an excellent question, actually. I'm glad you're asking this. The role of ERCP in this kind of injury is two possible roles to play. Number one, to help you make the diagnosis. Omar asked for MRCP to make the diagnosis, which is fine. Another way to make the diagnosis, if you're still suspicious, is ERCP. You can do ERCP, you see a pancreatic duct injury and leak, you can go to the operating room. That's fine. The second role, which is really important, is in the post-operative management. After your distal pancreatectomy and the pancreatic leak that you have, that's now about 2 weeks out. Ask your gastroenterologist colleague to come in, do ERCP, do sphincterotomy of the pancreatic duct, minus plus pancreatic duct stenting, take the pressure off, create a path of least resistance through the natural path of the duct, and allow the distal pancreatic fistula to heal. Again, this is the best pancreatic fistula that's gonna close spontaneously without any further treatment. That's the role of ERCP in pancreatic injury.
The second question, Prof, is the first case was presented 3 hours later. We have only 3 hours. Some textbook and some literature, and I saw a lot of papers, they talk about early finding within the first 6 hours. On the CT scan, it could be normal. You cannot exclude. The first sign, it could be peripancreatic fluid or edema, just of the parenchyma of the pancreas.
Yeah.
I have read some American study. They do serial amylase level It's not specific, but it has high sensitivity on the serial
Yes.
manner. I can do it 3, 4, 5 times to follow up the patient with it. What do you think of that, and any role or any follow-up plan for those patients إذا كانوا stable? If they are stable patient وأنا I have to observe them. الكلينيكال landmark بتاعتي بتكون at the cut point إنه والله to take this patient to the theater. What is it?
No, you can do serial amylase measurement. The initial amylase is not really that helpful, but rising amylase is a good sign. But you know something? If you see that, you're not going to run to the operating room. You're going to get a CAT scan. Your patient is still stable.
Okay.
You will get a CAT scan or MRCP. Actually, MRCP is not bad. It's a good thing. So rising amylase is going to guide you to get further imaging. Absolutely correct. Yeah.
Thank you so much, Prof. Jamal. It's Omar again. Can I ask a question, please?
Sure, absolutely, yes.
My question is, hello?
Yeah, I'm listening.
Hello, I can't hear. Hello?
I can hear you. I can hear you.
Yes. Sorry. My question is, what's the difference between, what makes the trauma wobble different from the other elective trauma? I mean, what is the surgical steps that I need to apply for a for the trauma wobbles? Thank you.
The main surgical principle you need to apply is never do it.
And if I have to do it, what's the difference between the
They
trauma?
they usually say, we have a saying here, don't do a trauma Whipple unless it's already done for you.
All right.
So you go in and the pancreatic head is transected, the duodenum is transected, all this, it's almost halfway done. One advice to say, besides always try to fight it, don't ever do it, is do it tomorrow. So, do the damage control tonight. Tomorrow, when the patient is more stable, do it. And it's the same principle like any elective Whipple, if the patient is stable, and the same anatomic features, right? So.
All right. Thank you so much, Prof.
Thank you. Any other questions or comments?
Prof.
Prof.
Yeah, it's Muhammad again. Sorry. On the same question of Omar, he said, suppose we have a major pancreatic injury with duodenal injury or duodenal injury with major pancreatic head injury with distal biliary system loss of tissues. The drainage procedure, the operative management for this patient. Can you tell us about the steps? What will be the difference in the drainage procedure, or it will be the same as the major duodenal laceration?
Okay,
last
that's good. So you're talking about repair, not a Whipple, right?
Not over, just drainage procedure for this.
Okay, now that's a good question. So I like the word you say, drainage, because most of the time with pancreas, just put a drain next to the pancreas, have a pancreatic fistula, and deal with it later. The duodenum, as we mentioned, major tissue loss, we just talked about plugging it with some omentum, getting a serosal patch, and doing the other things. The gallbladder is going to come out. That's not in question. So if the gallbladder is injured, you're going to do a cholecystectomy. If you have a common bile duct injury, please don't do it tonight. Do a damage control and get out. If you have a common bile duct injury, very likely you have a vascular injury, meaning portal vein and things like that. So deal with that. Come back tomorrow, look at the common bile duct. You may be able to repair the common bile duct over a T-tube. If you cannot do that, you can do a choledochoduodenostomy, which is very likely going to be the case because you have a healthy common bile duct here and nothing really major. You can do a choledochoduodenostomy. If you have an area in the duodenum, you can do a choledochoduodenostomy. This is not going to happen tonight. And you're gonna drain the area widely. So just remember, guys, the principles of damage control apply to these cases because of the nature of the combined injury of this. Deal with the important stuff tonight, drain things, leave the abdomen open, put a vac sponge, stabilize the patient, come back in 24 and 48 hours for reconstruction. Okay. Any other questions, guys?
Yes, Prof. Assalamu alaikum. This is Hassan speaking from Cape Town. Thank you very much for this very beautiful two cases presentation. I just would like to ask you, for the first case, the pediatric case presented, would you go at length at present?
No, yeah, it's a good question. I wouldn't go at length at preserving the spleen. No.
Okay, in this trauma situation, you would just go and take the spleen together.
And it's perfectly acceptable. Yes. Yeah.
Okay, yeah. Because I was going to ask you about the washout technique. Even if you ligate the splenic vessels and you keep it, you know, it's a pediatric case, you really want to keep the spleen. So you still go ahead and take.
Oh, yeah, I mean, unless you have plenty of time and the patient is very stable and all that's fine. But I think just remember the majority of times you're doing this in unfavorable circumstances. So.
Exactly. My question to you is, I think in a penetrating injury and you've got a duodenal hematoma, I think that's quite straightforward. You should assume, you know, there's a full thickness injury here.
Right,
and
you have to explore it, correct.
Yeah, and explore. But in the blunt trauma with hematoma, especially when it's quite extensive, what are your techniques? Do you use a go-rounder? Do you open the hematoma? Do you cut the serosa just to make sure that you're not leaving behind a full thickness injury that would cause problems later?
The answer to your question is yes. But I want to ask you a question. What's go-rounder? I don't know what that is.
A go-rounder is like a instrument that's quite blunt, and it comes in different sizes, and it's about 1 centimeter.
Okay, I don't know what
areas. Yeah, I don't know if there's another name for that. Yeah,
I think it's the right angle.
Sorry?
The right angle.
Oh,
no,
right.
Not right angle, Richard. There is a name for it.
Right angle forceps. Right angle forceps.
Okay, so it's a right angle hemostat, right? Yeah.
Yes, right angle hemostat.
Right. Okay. So that's fine. So you can do that and take the serosa. All you need to do is take the serosa off. And I want to remind you, here you're in the abdomen already. You're not gonna take somebody to the operating room just to do that, right? You're in the abdomen already. Yes, you can explore and make sure there is no full thickness loss or perforation, basically, in the duodenum underneath that. Yes.
Sure, thank you, Prof.
Using a right angle hemostat, yes.
Thank you. Shukran.
Thank you.
Hello, Prof.
Yeah.
I am Dr. Awak, Registrar of Surgery. I have one question about the first case presented.
Yeah.
It is a distal pancreatic duct injury. You say that you will transect the pancreas and you oversew it with stable. My question is that
I staple it and maybe oversew it, maybe, but I'll staple it.
Yes. My question is that can I do pancreatic genotomy instead of closing the duct?
Pancreatic genostomy on the proximal.
To the distal end of the proximal duct, instead of close it with stapler or oversewing.
No, you're gonna take the distal pancreas out, right?
Yes.
Okay, and now we have the proximal pancreas you're looking at, and there's a duct, right?
Yes.
I'm not sure why you would want to do this, though. I mean, why would you do an anastomosis that can leak And what's that going to add to you, though? I mean,
afraid about my suture itself, the closing duct suture. Is it better? The risk of leak is
well,
less.
the risk of leak is there regardless. So, do you know what's a good word actually? That's not mine. It's in the book about dealing with this kind of injury, and even with duodenal injury, they say that do the best so you can have a good failure. So you have a failure, don't have a good failure that's going to take care of itself. Pancreatic leak in these injuries, guaranteed almost, that's going to take care of itself. The most you're going to be having to do is ERCP and sphincterotomy. So you really wouldn't add anastomosis and do all this for this purpose. So, no.
So straightforward version or stable.
I'm sorry?
The better is overseen or do close it with stable.
Staple. And as I say, in this instance, honestly, most of the time what you have to do is the pancreas is almost transected. Get your GIA with white load or TA, thoracoabdominal non-cutting stapler, but usually GIA with white load, and stick the whole thing, artery, vein, parenchyma, and duct, everything in 1 or 2 staples. That's it. And you can oversew the duct or oversew the artery if you would, put a drain, put some hemostatic agents, you're going to be fine.
Okay, thank you.
Thank you.
Thank you.
All right, any other comments or questions, guys?
Sorry, Prof, again, Mohammed.
Yeah.
On the second case, penetrating abdominal trauma in a stable patient. This can give me time to do more investigation or to rush for laparotomy.
No, you can.
You asked me about
CAT scan. You can do a CAT scan. It's fine. You can do a CAT scan if you're really thinking that it's maybe it didn't penetrate the peritoneal cavity. And we're talking about a knife, stab, or gunshot wound.
No, step. Just like the case number 2.
Yeah,
we talked about the
you
knife.
may get lucky that the stab went through the liver parenchyma and didn't do anything else. I personally would get a CAT scan. Sure, stab, yeah. I probably wouldn't get a CAT scan if there's a gunshot wound transecting the entire abdomen from the front to the back in this area. Probably not. But for a stab wound, absolutely. I would get a CAT scan. I may actually get a CAT scan with a little bit of oral contrast, give me an idea about the duodenum for a stab wound. Because you may get lucky and the liver may be down, or the guy just took the knife and put it up like this and not straight back, put it up and went through the liver parenchyma. And that's going to take care of itself. You don't need an operation for that if the patient is hemodynamically stable, of course.
Prof, to be more specific, suppose this knife, it went through the duodenum and the patient is still stable, and I did the CT scan.
I wouldn't.
My question is about, my question is, if I have time to do more investigations to exclude other associated nearby injuries.
No.
Like MRCP.
No need. No. If you seem to be asking that that you're confident that it went through the duodenum and there's a duodenal injury. No, you need to go to the operating room.
Okay. Yeah.
Your exploration is going to be in the operating room.
Okay.
Thank you very much, Professor Gamal. And
Thank you.
Hope to see you.
Thank you.
Presenting more lectures and more discussion for us and for the registrars, and we learn a lot We are as Hepatobilirubin. We learn a lot from your approach. It's very
Inshallah,
fruitful.
it's
Inshallah.
inshallah. This is it's my honor and pleasure to be with you guys.
Thank you very much, Professor.
Thank you,
Hope to
guys.
see you.
Thank you.
Thank
Salaam
you very
alaikum.
much.
Salaam
Bye.
alaikum.
Assalamu alaikum.